Okay, let's unpack this. Picture yourself facing that huge stack of medical revision notes, feeling that familiar brain fog creeping in.
Oh, we've all been there, right?
Oh, absolutely. That feeling of just, where do I even start?
Precisely. And that's exactly why we created the deep dive, to take those crucial bits of information and really, dig into what matters efficiently.
Exactly. Think of this as your shortcut to understanding, hopefully leaving behind some of that overwhelm.
And today, our focus is sharp: variceal hemorrhage. We're using a really comprehensive set of revision notes here, and our aim is to build a clear, memorable overview that you can easily recall when you need it most, like for the MSRA.
Precisely. We'll systematically explore the key aspects, giving you a solid framework for your revision. Nice and logical.
So what's on the agenda then? We'll define variceal hemorrhage, then explore the etiology, that's the underlying causes, the risk factors that make it more likely, the step-by-step of the pathophysiology.
Yeah, how it actually happens, then how to tell it apart from other things, the differentials. Right. And the epidemiology, specifically here in the UK, what it actually looks like clinically, the investigations you'd order.
The management strategies, which are crucial, obviously, and then prognosis and potential complications down the line.
And importantly, we'll be weaving in mnemonics and memory tips throughout to try and make it stick.
Consider this your guided tour through, well, it's a complex topic, isn't it? Highlighting the essential landmarks for your learning.
All right, let's jump straight into the definition then. So, in simple terms, what is variceal hemorrhage?
Simply put, it's severe bleeding. It comes from enlarged, dilated veins. These are called varices in your digestive tract, usually the esophagus or stomach. Those are the most common spots.
Okay, so definitely more serious than your average nosebleed. And these varices, they're connected to something else going on, aren't they? Something underlying.
Absolutely. Variceal hemorrhage is, well, it's strongly linked to chronic liver disease. The risk of these sort of fragile veins rupturing and causing significant bleeding goes right up when there's high pressure in the portal vein system.
Ah, portal hypertension.
That's the one. That's the system carrying blood from your digestive organs to the liver. So portal hypertension is like a big traffic jam in that system, causing pressure to build up. And this increased pressure is often tied to how advanced the liver disease is.
So worse liver disease, higher pressure, higher risk of a bleed.
Generally, yes, that's the pattern. And while we mostly talk about esophageal and gastric varices, it's important to remember they can actually pop up elsewhere too.
Oh, really? Where else?
Yeah, places like the distal stomach, even the large and small intestine sometimes. Less common, but possible.
Crikey. Okay, need a memory anchor for this. How can we easily remember the basics?
Okay, try this. Think of varix, like a varicose vein. You know those bulging veins you see on legs sometimes? But these are internal.
Okay, internal varicose vein.
And hemorrhage, well, that just means it's burst and bleeding badly. So internal varicose vein that bursts and bleeds badly.
Got it. Internal varicose vein bursts, bleeds badly. That makes perfect sense. Okay, let's move on to the etiology, the causes. What's the primary driver behind all this?
The main culprit, as we just touched on, is that portal hypertension. And the most frequent reason for portal hypertension, certainly in the UK, is cirrhosis of the liver.
Cirrhosis, right. The scarring from long-term damage.
Exactly. And this portal hypertension, it can actually arise from different points in the system, can it?
Yes, exactly. It's helpful to categorize the causes based on where the blockage or the increased pressure is happening. We talk about prehepatic, intrahepatic, and posthepatic causes.
Okay, let's break those down. Prehepatic causes, first, what's going on before the liver.
So prehepatic issues involve problems before the blood even gets to the liver. Think about blockages or maybe increased blood flow in the portal vein itself.
Like a clot.
Yeah, exactly. Portal vein thrombosis, a blood clot in the portal vein, or maybe a physical obstruction, sometimes even something congenital like a narrowing or absence of part of the vein.
Okay.
Or you could have increased blood flow into the portal system, maybe from an abnormal connection, like a fistula, or even just a massively enlarged spleen pushing more blood through, increased splenic flow. So, issues with the plumbing leading to the liver.
Plumbing problems before the liver. Got it. What about intrahepatic causes then? Inside the liver itself.
Right. Intrahepatic means problems within the liver. And cirrhosis is the big one here, obviously. Doesn't matter the cause: alcohol, viral hepatitis B or C, autoimmune disease.
Yeah, cirrhosis is cirrhosis when it comes to portal pressure.
Pretty much. We also see something called idiopathic portal hypertension or hepatoportal sclerosis that's rarer, where the cause inside the liver isn't totally clear.
Okay.
And acute alcoholic hepatitis, even before full cirrhosis develops, can raise the pressure too. Then there are other things. schistosomiasis, that parasitic infection.
Yes, important globally.
Definitely. Congenital hepatic fibrosis, even things like myelosclerosis affecting the liver. So a whole range of issues damaging the liver tissue itself.
That's quite a list for intrahepatic causes. Okay, and finally, post-hepatic, after the liver.
Post-hepatic involves issues after the blood has left the liver. So maybe compression of the veins draining the liver, perhaps from a nearby tumor pressing down.
Makes sense.
But Chiari syndrome is a key one here. It's a blockage of the hepatic veins carrying blood away from the liver.
Right.
And then, much more rarely, you might get something like constrictive pericarditis, a heart condition causing a backlog of blood, right-sided heart failure, which can feed back and increase portal pressure.
Wow, okay. So blockages or problems before, within, or after the liver. That gives us a good map of the why. Now, to help us remember these, did you mention a mnemonic?
I did. Let's try this. For prehepatic, think P-BI. P for portal vein issues, thrombosis, obstruction. I for increased flow, like a fistula. And B for big spleen, increased spleen flow.
PIB for prehepatic. Okay, that works. What about intrahepatic?
For intrahepatic, try CIA. C for cirrhosis, and all its causes alcohol, viral, autoimmune. I for idiopathic portal hypertension. And A for acute other liver stuff like alcoholic hepatitis, schistosomiasis, congenital fibrosis.
CIA for intrahepatic. Got it. And posthepatic.
And posthepatic is BCT, B for Budd-Chiari, C for compression, like a tumor, and T for tamponade-like heart issue, constrictive pericarditis, or that rare right-sided heart failure link.
PIB, CIA, BCT. Okay, those are actually really helpful. Right now we know what causes the portal hypertension and varices. Let's talk risk factors. Who's most at risk of actually having a bleed?
Well, unsurprisingly, the biggest risk factors tie right back into the causes we just discussed. So advanced liver disease, especially cirrhosis, is number one.
Makes sense.
Then the things leading to cirrhosis, chronic alcohol abuse, chronic viral hepatitis B or C, they significantly bump up the risk. And really, any condition causing portal hypertension puts you at higher risk.
So the bottom line is, the worse the liver disease, the higher the portal pressure.
The greater the risk of a bleed.
Exactly.
Okay, let's get into the pathophysiology, the actual sequence of events. How do we get from high pressure to a massive bleed?
Okay, so it's a cascade, really. First, you've got the portal hypertension, that high pressure. The body, trying to cope, starts creating these alternative pathways for blood flow, bypassing the congested liver. These are the collateral vessels.
The body's trying to find a detour around the traffic jam.
Precisely. And when these collaterals form in the wall of the GI tract, especially the esophagus and stomach, they bulge out and become varices, these dilated, thin-walled veins.
So the varices are actually a compensatory mechanism, the body trying to help.
They are, yeah, an attempt to relieve that pressure. But the problem is these bypass routes, these varices, they aren't built for high pressure, high flow. They're fragile. So as the portal pressure stays high or even increases, and especially if the varices get bigger or develop these little red spots on the surface, we call them red whale markings or cherry red spots, which are signs of imminent rupture risk, they become incredibly likely to burst.
And when they burst,
that's when you get the severe bleeding into the GI tract, the variceal hemorrhage itself.
Right. The body solution creates a new, really dangerous problem.
Okay.
So a patient comes in, they're bleeding from their upper GI tract. How do we know if it's varices or something else? Let's talk differentials.
Yeah, this is absolutely critical. You have to consider other causes of an upper GI bleed. Top of the list is probably peptic ulcer disease, ulcers in the stomach, or duodenum.
Very common.
Very common. Then there's a Mallory-Weiss tear. That's a tear in the esophageal lining, often after forceful vomiting or retching.
Okay.
We absolutely have to think about malignancy, esophageal, or gastric cancer can present with bleeding. And another one to consider is angiodysplasia. These are fragile, abnormal little blood vessels in the GI tract lining that can bleed.
So quite a few possibilities. Is there a quick way to run through those common ones? A memory tip, maybe?
Yeah, how about this? Think PUMA for the common stuff first. P for peptic ulcer. U for Mallory-Weiss tear. Think upchecking causing the tear. M, well, Mallory-Weiss again, because it's important. And A for angiodysplasia.
PUMA.
And then always keep the more serious possibility in mind. Cancer. So PUMA and cancer.
PUMA and cancer. That's a good framework for the differentials. Okay, let's zoom out a bit. Epidemiology.
Yeah.
What does variceal hemorrhage look like in the UK population? Who gets this?
In the UK, it's primarily patients with underlying liver disease, and specifically cirrhosis. That's the main group.
Right.
We think around 40% of people with cirrhosis will develop varices at some point. And if you look just at esophageal varices, the prevalence in cirrhotic patients is really high. Figures range from, say, 40% up to even 95% in some studies.
Wow, 95%. That's huge. What about the actual risk of them bleeding once you have them?
The annual incidence of a first bleed in someone with cirrhosis who has varices, well, it varies depending on how big the varices are and how bad the liver disease is, but estimates are somewhere between 3%, maybe 22% per year.
That's quite a range.
It is. To break it down a bit, the one-year risk of a first bleed is maybe around 5% for small varices, but that jumps up significantly to about 15% if you have large varices.
So size really matters here.
Yeah.
Any other demographic points?
It does seem to be a bit more common in males than females. And in Western countries like the UK, the main underlying causes driving the cirrhosis are alcohol-related liver disease and viral hepatitis.
Okay.
And a really important point, despite all the advances in treatment, the mortality rate within the first 6 weeks after a variceal bleed happens is still pretty significant. We're talking 10, 20%.
And 20% mortality in 6 weeks. That really underlines the severity. Okay, so how does a patient typically present? What are the key clinical features that should make us think, this could be variceal hemorrhage?
Well, the most dramatic sign, often the first one, is Haematemesis, vomiting blood.
Okay. Bright red or?
It can be either bright red if it's a really brisk, fresh bleed,
Right.
or it might look like coffee grounds if the blood's been sitting in the stomach for a bit and got digested by the acid.
Yeah.
Another key symptom is Melena, those black, tarry, really foul-smelling stools. That's digested blood passing through the gut.
Okay. Haematemesis, Melena. Anything else?
If the bleeding is really fast and heavy, they might even have hematochezia, passing bright red blood from the rectum because it's moved through so quickly it hasn't had time to get digested.
Wow, okay.
And of course, with significant blood loss, you get signs of hypovolemic shock dizziness, feeling faint, fast heart rate, low blood pressure.
So the classic signs of a major upper GI bleed, but happening in someone who we might suspect has liver issues, are there other things to look for?
Yeah, they might also have more general symptoms like abdominal discomfort, and you'll often see features of their underlying liver disease jaundice. You know, the yellow skin and eyes, the cytics fluid buildup in the belly, maybe confusion or drowsiness from hepatic encephalopathy.
Okay, so look for the bleed and the liver disease signs. What about on examination?
Crucial signs to look for. Pallor, are they pale from blood loss? Hypotension, low blood pressure. Reduced urine output suggests poor kidney perfusion from low volume. Definitely do a rectal exam to check for Melena. Look for the physical signs of chronic liver disease, spider naevi, palmar erythema, gynecomastia. Check their GCS, the Glasgow Coma Scale, in case of encephalopathy or severe shock. And look for signs of sepsis too, like fever or a high white cell count, as infection is a risk here.
Right. A real combination of bleeding signs and liver disease signs should definitely ring alarm bells for variceal hemorrhage. Okay, so we suspect it. What investigations do we need? What's the plan?
The absolute cornerstone, both for diagnosis and often for initial management, is an urgent upper gastrointestinal endoscopy. OGD, esophagogastroduodenoscopy.
The camera test.
Exactly. You put a flexible camera down, you look directly at the esophagus, stomach, duodenum. You can see if varices are present, how big they are, and crucially, look for those high-risk signs like red spots or active bleeding.
And you can treat at the same time.
That's the beauty of it. It's diagnostic and therapeutic. You can often perform band ligation right then and there to stop the bleeding.
Okay, so endoscopy is king here. What about blood tests? What are we looking for?
Bloods are vital. Absolutely vital. Full blood count, FBC. Check the hemoglobin level, obviously. See how much blood they've lost. Look at the MCV, platelet count. Clotting profile is essential, particularly the INR, because the liver makes clotting factors. So liver disease often means impaired clotting.
Right, coagulopathy is counter.
Very. Then renal function tests, UNEs, check the kidneys are okay. Liver function tests, LFTs, to assess the liver damage. Blood urea nitrogen, BUN, can sometimes be raised disproportionately in upper GI bleeds. And maybe hepatic serology if the cause of the liver disease isn't already known.
A full picture from the bloods. What about imaging? Does that play much of a role in the acute setting?
Imaging has its place, maybe less so in the immediate emergency, but it's important for context and planning. Transient elastography, like FibroScan, can assess liver stiffness non-invasively, helping identify patients with chronic liver disease who are at higher risk of having varices in the first place.
Okay, risk stratification.
Yeah. Then there's hepatic vein pressure gradient measurement, HPTSI. That's actually the gold standard for diagnosing significant portal hypertension, but it's more specialized, not usually done right in the middle of an acute bleed.
Right.
Video capsule endoscopy is an option if you can't find the source on OGD, maybe looking further down. Doppler ultrasound can look at blood flow in the portal vein system. Check for clots, like portal vein thrombosis.
Useful for the underlying cause.
Exactly. And CT or MRI angiography can give really detailed pictures, again, looking for causes like thrombosis or Budd-Chiari. And a simple abdominal ultrasound might be done early on just to rule out other things like biliary obstruction causing abdominal symptoms.
So endoscopy is the immediate priority. Bloods give the physiological picture, and imaging helps with the underlying cause and risk assessment.
Okay, now the really critical part. Management. Someone comes in bleeding actively from varices. What's the absolute first thing we do?
Resuscitation, full stop.
Yeah.
ABCDE approach. Airway, make sure it's patent, protect it if needed. Breathing, give oxygen. Circulation, this is huge. Call for help immediately. Assess for shock. Get large bore IV access. 2 cannulas ideally. Start rapid fluid resuscitation crystalloids, maybe colloids.
Get the volume back up.
Exactly. Blood transfusion is almost always needed. You need cross-matched blood ready to go. Monitor their heart rate, blood pressure, urine output really closely. And critically, correct any coagulopathy they often need. Fresh frozen plasma, FFP, maybe platelets, vitamin K, address the anemia with packed red cells.
Stabilize, stabilize, stabilize. What happens once that initial resuscitation is underway?
Once they're hemodynamically stable, or at least stabilizing, then it's time for that urgent upper endoscopy. Ideally within 24 hours, but often sooner if the bleeding is ongoing. And that's where the banding comes in.
Yes, that's the main therapeutic intervention during endoscopy. Endoscopic variceal band ligation. You place small elastic bands around the base of the bleeding varices, strangulating them, cutting off the blood flow. It's very effective for esophageal varices.
What if banding isn't possible or doesn't work? Or if it's gastric varices?
Good question. For esophageal varices, if banding fails or isn't feasible, emergency sclerotherapy is an option. You inject a sclerosant solution directly into the varix to make it thrombose and scar up. For gastric varices, especially certain types like fundal varices, banding can be tricky. That's where glue injection comes in.
Ah, the glue.
Yeah, variceal obturation with tissue adhesive N-butyl-2 cyanoacrylate. You inject this special glue into the gastric varix, it rapidly hardens and blocks it off. It's quite effective for gastric varices.
Are there medications we give alongside this?
Yes, absolutely. Vasoactive drugs are started as soon as variceal bleeding is suspected, even before endoscopy. Terlipressin is the first-line choice in the UK.
How does it work?
It reduces portal pressure by causing vasoconstriction in the splanching circulation, the blood vessels supplying the gut. This reduces blood flow into the varices and helps control the bleeding. Vasopressin, sometimes with GTN, is another option that works similarly.
Okay. What about those balloon tubes like this Singh-Zek Blakemore tube? Are they still used?
They are, but really only as a temporary salvage measure, balloon tube tamponade. It's for severe, uncontrolled bleeding when endoscopy has failed or isn't immediately available, or maybe while waiting for a transfer or a more definitive procedure like TPS.
So it buys time.
Exactly. The balloons inflate inside the esophagus and stomach to put direct pressure on the varices. But it's only temporary, maybe 24 hours max, because they can cause serious complications like pressure necrosis or aspiration if left in too long. You need to get to definitive treatment quickly.
And that definitive treatment might be TPS. Remind us what that is again.
TPS, transjugular intrahepatic portosystemic shunt. It's done by interventional radiology. They go in via the jugular vein, down into the liver, and create a channel, usually with a stent, connecting a branch of the portal vein directly to a branch of the hepatic vein.
Creating an internal bypass.
Precisely. It bypasses the high-resistance liver, directly lowering the portal pressure. TPS is reserved for bleeding that can't be controlled with endoscopy and drugs, or for patients who keep rebleeding despite standard secondary prophylaxis.
A bigger gun for refractory cases. Is surgery ever needed acutely?
Very rarely these days. Procedures like esophageal transection or gastric devascularization exist where you surgically cut off the blood supply, but endoscopy and TIPS are usually preferred. Liver transplantation is the ultimate treatment for the underlying advanced liver disease, but that's not an acute fix for the bleed itself, more of a long-term solution.
Right. Any other key points in acute management?
Yeah, a few important things. Try to avoid sedatives if you can, as they can worsen or mask hepatic encephalopathy. These patients are sick, they need monitoring in a high-dependency or intensive care setting. Prophylactic 4V antibiotics are crucial, usually a broad-spectrum one like a cephalosporin,
Why antibiotic?
because patients with cirrhosis who bleed are at very high risk of developing bacterial infections, which significantly worsens their prognosis. So prophylaxis is standard practice. And of course, if they do develop hepatic encephalopathy, treat that actively, usually with lactulose.
Okay, a really intensive, multi-pronged approach. So that's the acute bleed sorted, hopefully. What about preventing it happening again or preventing the first bleed? Prophylaxis.
Prophylaxis is absolutely key. Let's talk primary prophylaxis first, preventing the first bleed in someone with known varices.
Okay.
If they have small varices but are deemed high risk, e.g. advanced cirrhosis, red signs on the varices, then non-selective beta blockers are often used. Drugs like propranolol or nadolol.
How do they help?
They reduce portal pressure by decreasing cardiac output and causing some splanchnic vasoconstriction. If patients have medium or large varices, the options are either non-selective beta blockers or prophylactic endoscopic band ligation sessions to obliterate the varices before they bleed.
Beta blockers or banding for primary prevention in bigger varices. What about secondary prophylaxis, stopping them bleeding again?
For secondary prophylaxis, after someone has already had a variceal bleed, the standard of care is combination therapy. Non-selective beta blockers, plus repeated sessions of endoscopic variceal band ligation until the varices are eradicated.
So hitting it with both drugs and endoscopy long-term. Okay, let's talk prognosis then. What does the future look like for someone after a variceal hemorrhage? And what are the main complications?
Well, the prognosis really hinges on two main things. The severity of their underlying liver disease, often assessed using scores like Child-Pugh or MELA-D, and how effectively the bleeding is controlled and, crucially, prevented from recurring.
And the potential complications.
The big ones are, unfortunately, recurrent bleeding, which remains a significant risk. Development or worsening of hepatic encephalopathy is common. And sadly, mortality is a major complication.
We talked about prevention of rebleeding. Just to recap, the prevention of the first hemorrhage strategy.
Sure. So if you screen someone with cirrhosis and find small varices, but they have high-risk features like advanced liver disease or red spots, you'd usually start non-selective beta blockers.
Okay.
If they have medium or large varices found on screening, the choice is between non-selective beta blockers indefinitely or starting endoscopic band ligation sessions.
And does everyone with cirrhosis get screened?
Yes. Current guidelines recommend that all patients newly diagnosed with cirrhosis should have an upper endoscopy to screen for varices.
And how often do they need checking after that?
If the initial endoscopy shows no varices, they might get screened again in maybe 2-3 years, or sooner if their liver disease worsens. If they have small varices, surveillance endoscopy is typically repeated every 1-2 years to check if they're getting bigger. Once they have medium-large varices and are on prophylaxis, beta blockers or banding, the surveillance intervals depend on the treatment, but ongoing monitoring is needed.
So lifelong surveillance and management, really.
For many, yes. And for those who've survived a bleed, it's lifelong secondary prophylaxis with beta blockers, maybe nitrates too, and ongoing endoscopic surveillance and treatment as needed.
Is there a target we aim for with treatment?
Ideally, yes. Reducing the hepatic vein pressure gradient, HVPG, to below 12 mmHg or by at least 20% from baseline is associated with a much lower risk of bleeding and improved survival. Though measuring HVPG isn't routine everywhere.
And the survival stats are quite sobering, aren't they?
They are. Even for patients who survive the initial bleed and get discharged, the estimated 1-year survival for cirrhotic patients after a variceal hemorrhage is only around 50%. It's a bit better for patients with non-cirrhotic portal fibrosis. Their underlying condition isn't usually progressive in the same way. But for cirrhotic patients, mortality is often linked to the severity of the liver failure itself, or development of other organ system problems like infection or kidney injury during or after the bleed.
A really stark reminder of how serious this is. Well, we have covered an enormous amount of ground there. A real deep dive into variceal hemorrhage from the definition right through etiology, presentation, investigation, complex management, and prognosis. Hopefully this has given you a really solid, high-yield overview for revision.
Yeah, we've tried to break down the essentials, flag up those mnemonics and tips, hopefully making this pretty challenging topic feel a bit more manageable as you prepare for exams like the MSRA.
And remember, this is just a framework. We really encourage you to go back to your notes, use this as a scaffold, and test yourself with practice questions to really embed this knowledge.
Absolutely. And maybe something to think about, just to leave you with. Considering that really high mortality we talked about, especially after a first bleed, what are the ethical implications around screening and offering potentially lifelong preventative treatments, like beta blockers or banding, particularly in patients with varying degrees of liver disease severity or perhaps other significant health issues?
That's a really interesting point. Where do the benefits outweigh the burdens and risks of treatment?
Yeah.
Definitely food for thought.
Yeah.
And for more excellent resources to help you nail the MSRA, do check out PassMSRA.com and also our free content site, FreemsSRA.com.
Lots of great stuff there to help you prepare.
Definitely. Well, until our next deep dive, keep learning and good luck with the revision.